Hey guys, hope you're doing well. Are most of you writing your Part A in coming in the next diet? Great, great, great. Hey, so today is going to be a very informal session, and we're going to be covering a very, very important topic today, and that is medical legal aspects of health and UK health, how the healthcare system in the UK is. Obviously, test and discussion, we focus on the questions which are difficult or which are important or the concepts which are again and again asked in the examinations. So that's going to be our focus for the test and discussion this time. Okay. And I'll try to make this as interactive as possible. There's going to be only one rule over here. You guys have to answer me. Okay. So that's going to be the rule over here. Okay. So let's start. I'll share my screen. So the first question. Matthew Bunnell was riding his uncle's bike and got into a motor vehicle accident. He's brought unconscious to the emergency room where a fast scan showed a ruptured spleen. His BP is dropping rapidly. An emergency splenectomy is proposed. Which of the following is the most appropriate action to be taken regarding consent for the surgery? Guys, so Abhilasha has told me E. E is proceed without consent. So let's look at the options. Contact the parents to seek consent. Makes sense. But do you have time to contact? The child is unconscious, needs a surgery immediately. Contact social services to seek consent, maybe. But you'll have to remember, this is 2 a.m. in the UK, if you worked in UK, you will know that nobody works after 5 o'clock in the evening. It's very difficult to catch hold of people. C, treatment cannot be initiated as the patient is unable to consent. D, consent by proxy. Guys, you'll have to answer me. So most of you have actually enrolled in the class, paid for the class. So, make sure you extract your money's worth. Answer. And that's when I want you to, if you're making a mistake, I want you to make a mistake so that you remember this until you pass your exams. So the best thing about, today's batch is that most of you are smart. The answer is actually D. So let's try to understand what does this consent by proxy actually mean. So there's an emergency situation. Okay. And it's not possible to wait for consent from the parent or the patient himself. Therefore, consent by proxy is what is done. So how does this work? This is actually basically consent form type 4. So if you want to understand consent, you have to understand types of consent form. Okay. So consent form 1 is patient agreeing to a treatment. Okay. I'm going to undergo a hernia surgery. I consent for treatment. That is consent form 1. Consent form 2 is parent or a person who is responsible for the child, for the ward, agrees to a treatment. 3, patient or parental agreement to an investigation where consciousness is not impaired. I'm going to undergo a lipoma excision under local anesthesia. That is consent form 3. Consent form 4 is patients who lack the capacity to consent to investigation or treatment. So now I'm going to undergo an endoscopy. Okay. It can be done under local anesthesia. So what consent form would that be? 1, 2, 3, or 4? It's me. So I'm all hoping that you guys believe that I have enough mental capacity to give consent. So you will ignore consent form 4. Guys, you have to answer my question. Okay, so the opinion is divided between 1 and 3. In endoscopy, there is always the risk that I might have to undergo sedation, which means that I will have to agree for consent form 1. So most of you are right. It is consent form 1. Despite the fact, but a lipoma, unlikely to be converted into a GA. Yes, technically, everything can go wrong. So most probably that is consent form 3. Okay. So for consent form 4, you will have to understand the concept. You guys can make a note of this. If a patient is unable to comprehend what you're saying, it does not mean that the patient does not understand the language name. So I tell a patient, Say I tell Praveen is a student over here. I tell Praveen, don't smoke. Smoking causes cancer. So if he does not understand what smoking means or what cancer means, that means he's intellectually impaired. So that means that you will have to, you know, mm, do consent form 4. Next, he's able to understand the language. He says, "Oh, okay, smoking causes cancer." You says cancer causes death. Okay, sir, now I understand. But what happens if I die? Or what happens if I get cancer? Which means that he's able to understand the language. He's able to understand, he's able to comprehend what you're saying, but he's not able to use that, information to, analyze what is gone. He's not able to, understand the gravity of the situation. Now there will be some sort of people who will understand everything. You tell them, Praveen, smoking causes cancer. If Praveen tells me, yes, doctor, I want to die. Dying is my main aim of my life. That means that he's able to comprehend, he's able to understand, but he's unable to use that information to take a right decision. So in all these three situations, you use consent form 4. In our medical situation, patient with dementia, patient with severe mental illness, schizophrenia can be consent form 4. Okay. Also, if a patient is unconscious due to some reason, it could be hepatic encephalopathy, it can be uremic encephalopathy, it can be unconsciousness due to trauma, whatever be the reason, it is consent form 4. If you notice, in consent form 2 or 3, where a parent is involved, I did not talk about the age because there is no set age limit. I'll come to that in a while. So, yeah. So, does anybody know what Gillick competence means? So, there was this lady, Victoria Gillick. She had a major problem with a young girl choosing to meet a doctor on her own and getting abortion pills. She said, no, 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 no. Patient, if she's a 14-year-old girl, even if she has had sex, even if she understands that she's going to get pregnant, her parents have to give consent for abortion. That law did not pass. She filed a court case. It went to the House of Lords, the Parliament, the equivalent of Parliament in the UK, the Rajya Sabha in the UK. And everybody decided that no, you know, if a child has enough mental capacity to take decisions on their own, like all the three conditions which we told, they're able to understand the language, they're able to comprehend the information, they're able to use that information to take right decisions. That means that the child is Gillick competent. Kind of a sad story because she didn't want to be named after that, but that's called as Gillick competence. She was a kind of a very religious person who was against reproductive rights. So coming to the real point over here, there is no specific age limit. Certain materials tell you Scotland it is 16, England it is 18, but for us it doesn't matter. Don't get confused seeing the age. If a 12-year-old child can take decisions on their own, the child can give its own consent. And in the UK, concept of attenders giving consent does not exist. It is only the individual themselves. If the individual does not give consent, the consultant can use consent form 4 and give consent. Am I being clear, guys? Or should I go slow? Should I go fast? You guys have to tell me. You guys are very poor at responding. That's for sure. Okay, so let's come to the next question. Okay. So Ralph Mosley is found under a pile of rubble at a building. The right thigh is crushed badly. The surgeon feels that the limb is unsalvageable, confused, disoriented, urine test positive for myoglobin, dark looking. His wife states that since his brother lost his leg in Iraq, the patient has said several times he would rather go through anything other than lose a leg. What is the correct management for this patient? A, B, forgive the options. It's A, B, C, D, E. It's not A, B, D, E. So you wait for his consciousness to return, or you want to speak to the brother and to ask him whether they are okay with managing palliatively. Attempt to call the on-call legal team. Remember, that is never the option, because the on-call legal team, you're not going to be able to find them. Option last D, following discussion, book the patient for a below-knee amputation, or follow the discussion with the child mother, with the patient's wife, book the for a high amputation. What is the answer? Oh, so I think I'm going to go back because Husna and Uswa have asked me to repeat about Gillick competence. I'm just going to go back, think about this question while we go back and come back again. So Gillick competence uh, means that if a child is capable of understanding the problem and taking a decision, the child can give consent. There is no specific age limit. I'm repeating, there's no specific age limit. But it's usually around 10 to 12 years. Usually slightly lesser for girls, but that's all, depends on the doctor. And Dr. Uswa has asked me a doubt. Sir, if only age is given and nothing else, then how are we going to know the consent form? See, it's not going to be ambiguous. The question is not going to be ambiguous. They're going to give you a lot of information on the question. They're going to tell you that the child is able to understand, comprehend. Uh, and only then you get to this thing. And they won't ask you specifically, it's consent form 4, consent form 2. They won't ask you like that. They will only ask you what decision you are supposed to take, and it's going to be very clear. See, I'm explaining Gillick competence because I don't want you to make a mistake. I want you to understand everything in detail. But if you kind of look at the question over here specifically, I've been very clear. The child is uh, unconscious. The 17-year-old Matthew is unconscious, which means that you will have to go for consent by proxy. Consent by proxy is another name for consent form 4. I'm going to the next question, coming back to the same question. So there's again another situation where the patient is disoriented and confused. So what would you do in this particular situation? Guys, you'll have to answer. Yes, you guys are smart. Then why are you not answering? You're all getting it correct. This is, literally the easiest question. I spent a whole lifetime explaining in the previous question. The person is disoriented and confused. Consent form 4. I mean, consent form 4, which means you go in for a high amputation. Why high amputation? Because his right thigh is crushed. If you go for a below knee amputation as an option D, it's not going to work. Okay, that's it. So you'll just have to apply your mind a little bit. Okay. The reason why you want to have a discussion with the patient's wife is you don't need the wife's consent. Okay, but you always take decisions in consultation with the patient's family. It does not mean that they have to give consent, but you will have to inform them because the patient is unconscious right now. Okay. Okay. Next, now comes the googly. Now let's see who answers this. No, whoever answers this gets a chocolate from me. Okay. So last batch there was a guy who texted me after 1 week and told me, "Sir, you promised me a chocolate." I said, "It'll take some time for me to courier it to you, but I'll give it to you for sure." Okay, Gregory King has a 55-year-old man has been brought to your emergency room by the paramedics, accompanied by a policeman. They tell you he's a bus driver. He's just driven into a tree, injuring himself and two passengers. He has a laceration on his head and appears disoriented, confused. The policeman asks you to obtain a blood sample to test the blood alcohol concentration, but you can see that Gregory is not capable of giving consent for this at present. What is the most appropriate action in these circumstances? Take a sample now, wait till Gregory can give consent. Does that make sense? Let's see. Take a blood sample, but wait till Gregory is alert and oriented before testing, regardless of his willingness. Does it make sense? Or, I mean, I don't know. Take a blood sample immediately and give it for analysis as this is a medico-legal case. No? This is how things work in the subcontinent. Take consent from Gregory's emergency contact and draw the blood sample for immediate analysis. E. Inform the patient and policeman that you can only draw the sample once Gregory is able to consent for it. C, C, D, B, D, E. Akhil Vincent, A. So, this question is one of the reasons why you need to participate in this testing discussion, because this is one of the most confusing questions ever in MRCS history. This is a question which has been asked not regularly, but at regular intervals, to be honest. The answer is A. I'll explain to you why this is. This is according to Police Reform Act. So what they say is that it's going to be very confusing. So you'll have to listen to me very carefully. And if you're not able to understand, I'm going to repeat it again. Police Reform Act says that you don't need consent from unconscious or incapacitated drivers to take sample. To take sample, you don't need consent. But to test it, you need consent. But now comes the googly. Now, a competent patient who refuses his sample to be tested is liable for prosecution. In this way, new law recognizes the clinician's duty for justice. So you need to sample him. Testing can be done later. I'll have to change this. It's not tested right away. It needs to be sampled right away. So you now get the point. Now you might ask me, what is the logic, Vinayak? If you need consent for sampling, then it means that consent for testing. And if he wants to give consent for testing, but if he doesn't give consent, then he can be prosecuted. And you might say that this is confusing, but unfortunately, law, like in most countries, it is very confusing and we cannot fathom it. Which means that you will have to understand this, remember this, and go and solve this question in your exam. And when you become consultants in UK, you will have to remember this. But at that point of time, there will be a lot of people to help you. Okay, I'm going to repeat this again. Medico-legal case or whatever case, if a patient is unconscious, you don't need consent to sample, to take the blood sample, but you need consent to test him. If at that point of time, he is capable of giving consent. But obviously, if he's not capable of giving consent, even after a few days, few weeks, when the court case becomes this thing, you will have to sample it. Okay. But if he refuses consent at that point of time, he can be prosecuted. Yes, Usna, he can be prosecuted. Usna has asked it out. What is the logic, Vinayak? How can he be prosecuted if he denies sampling? Because he has consent, then what's the point of asking consent? But that's the entire point. There's no logic in this, and you will have to remember this. Hope you all understand. Guys, am I being clear? Yes. Let's go. Okay. I think there's only one person who got it right. I think it was Somtirth, if I remember right. Yeah. Again, I'm going to bore you with consent because I want all of you to understand this concept really well. While consenting a patient for an invasive intervention, which of the following is not information that must be provided for the consent to be valid? Read the options, guys. Explanation of risk and benefit, explanation of the purpose has to be done, explanation of whether the treatment is experimental or success rate, other options for management of risk and benefit, success rate of the doctor who will perform this thing. Now all of you guys are getting it right, but you still need to answer. There's no way you can escape from answering this. It is answer E. So what is the information you should be giving? Details of the diagnosis, management, what are the further options, purpose of this treatment, benefits, problems, side effects, the name of the doctor who will have overall responsibility for the treatment, and the other senior members of the team. Also, a reminder that patient has a right to seek a second opinion and they may change their minds about a decision at any time. This is very important. Also, the patient should be informed of the surgeon's own complication rate for the procedure. You don't need to give a comparative figure against the national rate of complication. There's a logic for this. Well, there are surgeons who by nature are risk taking, which means that they will be performing riskier cases, more complex cases. Now, if you want to compare them with the national average, their rate of complications are going to be higher because they're dealing with more complex case. So that's why they have meant that you don't need to talk about a comparative figure. Nothing too great to understand. Next question, simple. While obtaining consent, which of the following is not true? Provision of translators is necessary if the patient doesn't understand language. Makes sense. Any member of the surgical team can take consent. Does it make sense? Let's see. Enough time must be given for the patient to arrive at a decision. Makes sense. Consent should be taken in a quiet room. Yes, all of the above. Guys, now you guys are smart. Most of you have got it right. Any member cannot take consent. Ideally, only the operating surgeon should take consent. But if the operating surgeon is stuck in a case somewhere, he's stuck in an emergency, then the next senior mouse member can take the consent. Okay. The consent should be taken in a quiet venue and enough time must be given to decide. Translators are a must when the patient does not understand the language in which the consent is being taken. Okay. Class on medical ethics at Birmingham had a heated discussion on patient confidentiality. Which of the following circumstances is not a valid reason to breach patient confidentiality? You want to discuss the patient information with another specialist, with the next of kin, when the patient is unable to make decisions themselves. So if a patient is stable, patient is stable in the sense that if the patient is conscious, competent to take decisions, then you need the permission of the patient to discuss it with the next of kin. You can discuss it with the next of kin only if the patient is unable to, communicate or is unable to make decisions on their own. Disclosing confidential information to the police or social worker when the patient is a threat to themselves or others for the society. Highly communicable disease. Discussing it with medical students at rounds. You guys are smart, man. It is easy. So you can't discuss it with a medical student at rounds. Okay. Everything else, public safety, notifiable disease, everything has to be done. Okay. Now let's come to a very interesting question. This, my dears, is the most common question in the exam. Who is authorized to diagnose brain death, brainstem death? Guys, I want your answers. This is one question which is repeated in almost every single exam. Two doctors, should both of them be a consultant? Yes or no? So the question doubt is between option C, option B, option E. So someone has told option C. Now, option C, the biggest problem is that one of whom must be a member of the transplant team. When one member becomes a part of the transplant team, here is where a major ethical question comes. There should be nobody in the transplant team who should be certifying brain death. Remember this, remember this, remember this. This question can be twisted and asked in multiple ways, but this is something you should remember. The transplant team is going to benefit. They're going to operate. Surgeons, they love operating. So they never make decisions about brain death. So the answer, like most of you told, is answer E. Two doctors, both should be 5 years post-registration, and one of them must be a consultant. Neither of them are a member of the transplant team. So 4 criteria. Two doctors, number one. Number two, 5 years post-registration. Number three, one of them is a consultant. Number four, nobody is a part of the transplant team. Okay. Okay. Which of the following is not one of the 7 pillars of clinical governance? So in this question, what do I expect from you? I don't expect anything from you in this question because this question, there's no logic. You will have to remember what is the 7 pillars of clinical governance and you will have to answer. If someone knows the answer, great. And does anyone know the answer? ED, it is cost control. Cost control is not a part of the 7 pillars of clinical governance. You have to remember this: clinical audit, risk management, clinical effectiveness, education and training, and continuous professional development, patient and public involvement, use of information, staffing and staff management. To have good clinical governance, all these 7 key areas must be in place. That's it. You'll have to remember this. No major issue in this. Commonly asked question, but you will have to remember. Okay. Now let's come to the next question. Sorry for the double options mentioned. So 9-month child to the ER gives inconsistent history. Which injury most raises the suspicion of non-accidental injury? Guys, anterior rib fractures, clubfoot deformity, femoral shaft fracture, hip dislocation, bruising over both knees. Okay, this is one more question why you actually need to attend this test and discussion. Okay, somebody has told me bruising over both knees. So who's that? So let's come to that option. Start from that. We were 2 brothers. Now both of us are surgeons. When we were kids, there was never a period of time in our lives when our knees were not bruised. We used to play football in the concrete, cricket in our near our home, and always there was bruising over the knees. Bruising over the knees in children is very common. It's a 9-month-old child. It'll be crawling. It crawls on some carpet. It'll have a bruise in the knee. Hip dislocation, congenital hip dislocation is one of the most common congenital anomalies, man. So you can't ignore that. Let's come to anterior rib fractures. Clubfoot is a deformity. So there are 2 options left: anterior rib fracture and femoral shaft fracture. So I'm going to show you a demo. This is a volume 1 of Quran pediatric surgery, and this is my baby. So, I'm a pediatric surgery guy. So, I've seen these cases. It's very painful when you see abuse. These rib fractures happen when the child is shaken like this, crushed like this by the hands. Now, if you look at it, I'm facing the child, to the back of the child. 4 fingers posterior. Okay. Which means I'm applying a lot of pressure back, which means that the posterior rib fractures are more common than anterior rib fractures. Anterior, only 1 finger, posterior, 4 fingers, crushing. The posterior rib fractures are more common. And why is this a sign of non-accidental injury? Ribs are very supple. They don't break easily. Only if you put a lot of pressure, they break easily. Okay, so answer A is wrong because it's not anterior rib fracture, it's posterior rib fracture. Femoral shaft fractures, long bone fractures in a child who is walking is okay, but in a child who is not walking, extremely suspicious. It is only non-accidental injury. Remember this, remember this, remember this. Okay. Hip dislocation, not a problem, common. But a femoral shaft fracture in a child who is not walking, a 9-month-old child does not walk. Now that is suspicious and that is non-accidental injury. Am I being clear, guys? Guys, you guys have to respond. Is my video visible? Ratika told me that the video is not visible. Okay. Okay. So red flags. Long bone fracture in a child who is not walking. Multiple fractures in various stages of healing. You take an X-ray, you take a baby gram. That's what they call the whole body X-ray. You'll find that some fractures are in early stage, some fractures in late stage, which means that the child abuse is a recurrent pattern. And child abuse, are really crazy individuals. I've seen a lot of these people. Some of the worst people you will ever meet in your life. I hope you never have to meet them. Corner fractures, and transphyseal separation. When you twist the arm like this, there are, transphyseal separation of the humerus and corner fractures, posterior rib fractures. Now, these children should be admitted to the hospital and appropriate child protection services should be called. Okay. So, yes. So, what are bad burns? Again, very painful to see. cigarette burns, one or more rounded ulcers with singed villus hairs, branding injury, fork, spoon, immersion injuries of the buttocks. When you dip the child over there, the buttocks will be freed. And, our fingers are relatively, you can bath in pretty hot water, but a child will kind of struggle to bathe in hot water. So, that is going to cause a lot of pain to the child. And where the child is dipped, that area will be spared. And where your hands are holding the child, that area will be spared. So that classical glove and stocking distribution, donut type sparing in the buttocks, all these are indicative of non-accidental injury or bad burns. Cigarette burns, very painful to see. I've seen a couple of them. Uh, you know, the trauma is really bad. Okay, pure legal question. Again, I have very less expectations out of you in this question. Well, let's see if you guys are able to answer. 18-year-old lady, Alzheimer's, needs just elective surgery for a squamous cell carcinoma cheek. Son tells you, I have a LPA, lasting power of attorney, and I'll be able to give consent. Now, which of the statements regarding an LPA is true? Okay. Yeah. Health and welfare LPA allows decisions to be made on the donor's medical care and life sustaining daily treatment care and living arrangements. Is this true? Let's see. Health and welfare LPA comes into effect as soon as it is registered. Let's see. LPA can be made by anyone who is more than 16 or over, can be made by anyone who is 18 or over. If there is more than one attorney registered, they must both give consent for medical care decisions. What is the answer? Easy question. If you kind of think about it, it's not difficult. So let's see what's an LPA. LPA is a legal document. It's made by a person who's called as a donor. Okay. Now this is done before they lose mental capacity. Say, for example, I've been diagnosed with Huntington's chorea or multiple sclerosis. So I nominate my friend, my spouse, my partner, my father, someone I nominate. I can nominate 1, 2, 3, how many people I want. Those are called attorneys. And once you make this LPA, it should be registered with the OPG, Office of the Public Guardian. Kind of difficult for you to understand. You'll have to go through this video again to understand this. This is there in the question bank as well. So this donor is someone whom you trust. It can be anyone. It can be a friend, lawyer, spouse, anyone. Must act in the donor's best interest because you trust someone, right? You trust that your mother will take the decision, what you have, the best decision she has in mind, she'll do that for you. But this is different from a financial LPA. A financial LPA will come into effect once it is registered, but a health and welfare LPA will come into effect only when the donor loses capacity to make decisions. So I have multiple sclerosis. I'm still okay. It will come into effect only when I am, say, 60 years old or 40 years old, whenever I lose my mental capacity. Now, to make this, you'll have to be 18 years old. So each LPA, the terms are different. If you kind of look at the last option, if there's more than one attorney registered, both must give consent, doesn't mean, it can mean that. In the LPA, if it is written that both must give consent, then both must give consent. If it is written either or, if one of them should give consent, that's enough, then one of them can need consent. The terms are defined by the donor. Okay. So option A is correct. If you look at option C and option E, option D and option C, option D and LPA cannot be validly made by anyone 18 or over. No, that is wrong, obviously. So, just read the options correctly and answer. Okay. So, yeah. So, can someone tell me who is the person smoking? As you guys are all super serious that you don't watch TV at all. Nobody knows that. Nobody watches Marvel. Yeah. Now I got the answer. Yeah. Okay. That's Robert Downey Jr. Great. So you walked into the doctor's room at 2 a.m. and you see a register. Dr. Mayer smoking cannabis peacefully while on call. She even has a pager on her when she drags the fumes into her lungs. She says she has quite a stressful week and has only one joint to help her relax. What would you do? As it is a quiet night, ask for assurance that this is the last time and carry on. Ask her to arrange for someone else to do the call on for her and nothing more will be said. Ask her to discuss the matter with the consultant in the morning and carry on. Ask her to phone her consultant to self report immediately. Phone the GMC on call line for service. Vishwas has told option E. If you remember, I told you this is the UK. After 5 p.m., nobody will pick up the call. If you're registered for your exam and you try calling up the Royal College, you're out. It's not very easy to call them after outside office hours. I mean, that's true for any office, even in India or in abroad. So at 2 a.m., do you think GMC will respond? They won't. So a couple of sessions ago, I think 4 or 5 sessions ago, there was one guy who put option F as like, fuck man, there's no option F. And he told the option F is ask her to share the joint with me so that I can also relax. That's not an option. Yeah, that was just for fun, guys. Don't take it seriously. Okay. So the funda over here is that a lot of you are saying option C. Ask her to discuss with the consultant in the morning and carry on. But the fact is that if you wait till morning, you are committing a crime because she is on call. So the correct answer is option D. You will have to ask her to phone the consultant. Now, this is a very, very, very common situation. And a lot of you guys make mistakes in this, but you are my students, and I'll take it as a personal insult if you miss these questions. So she should self-report immediately. And if she does not, you should call. Don't think that you are being a snitch, but that's your responsibility if you want to work in the NHS. Now, it's a consultant responsibility out of ours to deal with this in the first instance. So she has to be removed from the clinical environment, and consultant should facilitate this by stepping down as to act as a registrar. That's called a stepping down because there is a problem and he has to step down. Another doctor does need to complete her call to protect patient safety. However, the issue should be escalated and not forgotten after this. The consultant's responsibility to deal with this, he or she should report it to both the trust and the GMC. Once the situation is made safe, it is likely that the registrar will face both trust and GMC disciplinary proceedings in due course. So guys, life lessons, please don't smoke or drink while you are at work. Extremely important. Don't get caught also. Okay. Okay. One more consent situation. Let's keep it simple. Jehovah's Witness, they don't accept blood donation. Child is in grade 4 shock. Lost more than 40% blood. Father states he would rather see his child die than receive a blood transfusion. What is the correct management for this child? So I'll give the options. It's A, B, C, D, E, not A, B, C, C, D. See, again. Guys, you're making the same mistake. People have said option C. They're telling me urgent legal advice. Where will you call? Imagine this is 2 a.m. emergency surgery. You cannot call the legal team at this point of time. Usually there's a Jehovah's Witness license cell. Basically, there's not even just a legal team. There's a Jehovah's Witness license cell in almost every major hospital in the UK. But they also will not pick up the phone after 5 o'clock in the evening. So option C is non-negotiable. Okay, it's not there. Okay. Accept the patient respect. Will you see the child die? Not right. Okay. Yes, now you guys are getting the answer right. It is option B. So telephone the elders of the father's community to schedule a meeting. You don't have time. The child is in grade 4 shock. Telephone the on-cast trust barrister. So option C, D, E, all making calls doesn't work. It is option B. So use your logic. This is a very logical scheme of things. And this is exactly the reason why you should attend these test and discussions to understand the logic behind these decisions. It's not just reading the option because you have to understand why you have to do these things. So there's no point calling the legal team. There's no point calling the elders of the community. There's no point calling the Jehovah's Witness license cell. There's no point asking for legal advice at 2 a.m. in the morning. You should transfuse the child with group O negative blood while you wait the results of the group. And why do you transfuse that? Because this comes under Children's Act 2005. Okay. This is similar to consent form 4, except that the legal name is different, but the funda is same. In children less than 12 years or older children that lack capacity, medical treatment or surgery cannot be performed without parent or consent guardian. Unless for life-saving treatment, when the child doctor can act in the best interest of the child, and in this case, administer the blood transfusion. Even this 12 years is okay. If the child can give consent, it's okay. But this is an emergency situation. Especially this is here you apply Children's Act 2005 and save the child's life. Okay. So don't worry too much about consent form 2, 3, or 4. The question is not going to be asked about consent form 2, 3, 4 or Children's Act. It will be according to the decision you take. And here you will have to transfuse with O negative blood. So does anyone recognize the character? Looks like I'm the only one watching a lot of shows. What show is this at least? Every batch, at least one person ends up answering this. Praveen has answered. It's Brooklyn 911. And who's the character over there? He recently died as well. Okay, I don't think I should waste too much time. You guys will kill me. Okay, tough question. You're a young surgeon from India who's just joined as a registrar in the NHS. You're super interested in teaching students for their exams because you believe teaching makes you a better doctor. It does actually. Which one of the following statements is correct regarding teaching and training in the NHS? Any consultant who has been in post for more than 3 years can be an educational supervisor. Any consultant who has been in post for more than 5 years can be a clinical supervisor. Evidence of teaching is important and forms a formal part of the appraisal process. It is only recognized trainers who have taken part in the necessary training themselves can teach in NHS. Workplace-based assessments can only be taken by consultants. What is true? C, D, E. Guys. It's actually a difficult question. A lot of D's, a couple of A's. The answer is very simple. There's nothing major. Evidence of teaching is important and forms a formal part of the appraisal process. So let's kind of get this clear. Teaching is a part of appraisal. What is appraisal? I'll tell you. Next question comes over there. And it's a part of the duties of a doctor. So any consultant who would like to be an educational supervisor, there are multiple terms, education supervisor, clinical supervisors and all. What is this education supervisor? I will talk. Has to have passed a qualified educational supervisor program or similar. So just that if you want to become a supervisor, anybody can teach if you're interested. But if you want to become an education supervisor, you have to undergo training. So only consultant that have passed the qualified education supervisor can become clinical supervisor. Okay. So this education supervisor, clinical supervisor, pretty much the same. Okay. But the point is that in some hospitals they call them clinical, some hospitals they call them education. That doesn't matter. But what matters is that the time duration after becoming a consultant is not relevant. And ideally, they should be a consultant. Again, if you are a trainer, if you are a teacher, you should have some training relevant to the field, but anybody interested in teaching should be allowed to teach. Workplace-based assessments can be completed by middle grade doctors and consultants. Okay. It's that what workplace-based assessment, everything we'll look into the next question. Okay. Now here comes a very important question. It's the last question for the day. Yeah, the workplace-based assessments need not be a consultant. You can make a note of that point. So you are preparing for your appraisal, collecting relevant evidence. It will be the closest appraisal prior to your revalidation. What is appraisal? What is revalidation? Everything we'll look into it. Which of the following statement is most accurate regarding this appraisal? A revalidation. So have a look at the options. I'm not going to read it out to them. read it out to you guys. Have a look at this and I'll come back to it. Let's see what appraisal is. We'll come back to the question again. Medical appraisal is an annual process. Remember, medical appraisal is an annual process. Now, this is done between a doctor, everybody has to undergo appraisal. I have to undergo appraisal if I'm in the NHS. Some Tirtha has to undergo if you are in the, if he or she is in the NHS. And the appraiser is a colleague who is trained as an appraiser. Appraiser is a skilled individual who is trained in the process. There are 3 stages in this appraisal. Inputs to the appraisal, including a record of the doctor's scope, nature of work, everything. What and all the doctor has done, that's the input. Then there's a confidential appraisal discussion, okay, between the doctor and the appraiser. Outputs of the appraisal, including the doctor's personal development plan, summary of the appraiser discussion, and the appraiser statements. So the appraisers can be from various backgrounds. It can be locums, it can be staff, it can be associate specialist care doctors. It need not be a consultant. Client, colleague, and patient feedback are supporting evidence for appraisal for revalidation, and both are equally important. So both colleague feedback is also important, patient feedback is also important. So every year you undergo an appraisal, and every 5 years you undergo revalidation. So remember this, every year appraisal, every 5 years revalidation. You guys get the point? Are you guys able to see my video?
Yes, sir.
Yeah. Okay. So feedback from colleagues can be in the form of 360-degree feedback. Now this feedback is a very important part of revalidation, but it need not be included in every appraisal. If you want to, you can. But this feedback from colleagues, the 360-degree feedback, is a part of revalidation. Okay. So remember, feedback is mainly for revalidation. It can also be part of appraisal. Appraisal is a important part of the revalidation process. You know, they will, when you are doing a revalidation, they will look at your appraisals. But appraisal is only every year and revalidation is only once in every 5 years. So let's go back to the option. Now let's look at revalidation. Revalidation is done by the GMC. Everybody who needs to retain the license and needs to undergo revalidation. So mainly why it does, to assure the public that, you know, your healthcare professionals are, you know, are good to do this thing. So the revalidation is done by a responsible officer. Now for this, there is usually a senior doctor in the organization. So usually it will be a consultant. Okay. So let's look at the option again. A revalidation appraisal is required every 3 years. For revalidation every 6 years, wrong. It's done every 1 year, every 5 years. Feedback from colleagues is a lower weighting than feedback from patients. No, both have equal weightage. Your appraisal can be carried out by a non-consultant grade doctor. No, yes, that is true. Your appraisal should be carried out by NHS consultant who has been on the feedback register for 5 years. No, that's not true. 360-degree feedback is essential part of your appraisal. No, it's essential part of your revalidation. Okay. So the answer is C. Hope you guys had a good session. Did you guys find it useful? Great. So the funda over here is that I want you guys to start using the question bank. We've had a great result this time. The exam was tough, but if you kind of look at it, most of our students passed. And the reason was that the question bank is a tough question bank. I'll accept it. When you guys start doing the questions, you will start doing other platforms and you will say, Vinayak, your question bank is too tough. I find it difficult. I find it demoralizing. But the point is not to demoralize you. The point is to make you ready for real life. And I'm not going to model cuddle you. I'm not going to tell you that you will all pass. You need to work hard to pass. You need to download. Okay, someone has asked me, how do we register for it? You need to download the app and use the question bank. Or you can contact the helpline because you have already registered for the TND. You will get a discount on that as well. But the point which I'm trying to make is that you need to practice at least 50 questions every single day. There's no combination package, Vishwas. There's no combination package. You'll have to subscribe separately, but you will get a discount. Just do contact the helpline. Ankur, can you just drop the helpline number in the chat?
Yes, sir.
Yeah, yeah. So what I wanted to tell you was it is going to be a tough game. You will have to study, which means that you will have to study for 2 to 3 hours every single day. And every single day, you will have to solve at least 30 to 40 questions. And those questions are going to be difficult. Solve them in the practice mode. Make a note of those points. Go back and read. What textbook you should be reading? You should be reading from Raftery for basic sciences, Bailey and Love for the general surgery part of it, principles of surgery part of it. Someone has asked it out. It's still showing for Jan 2025 that the testing discussion. Yes, it will be activated in 2 days. You don't. All you need to do is contact the helpline, and you will be able to subscribe to it. The videos will be uploaded in over the next 2 days. Okay, you can just drop a message to the helpline, and it will be activated. The recorded videos will take about 48 hours for you to join. Okay. So Husna has asked me, if we dedicate 6 to 8 hours starting now, can we pass the exam comfortably? Even 3 hours per day, if you put focus 3 hours per day, you can easily pass the exam. Preparation is going to be difficult for everyone. So, online platforms, hundreds of people will say 100 different things. But your basal knowledge is very different. Someone who has just finished MBBS is going to be good at basic sciences, but principles of surgery, they're going to be weak. Someone who has been a practicing surgeon for the last 3 or 4 years, they're going to find basic sciences difficult, and they're going to find principles of surgery easy. So every person is different. And I want you guys to work really hard, practice the question bank, and crack the exam. So Sai Krishna has asked me, can you repeat the name of the books? Raftery for basic sciences and Bailey and Love for principles of surgery in general. Do we need to refer FOSSIA sheets? You can refer, but the recall questions from the question bank are sufficient because these are the latest recalls. The most of the concepts in the FOSSIA sheets are covered in the question bank, and the latest recalls. When I mean the latest recalls, if you kind of look at the recalls, old recalls of 1995, 2017, 18, and all are not going to be asked. Only recalls from 2020 are going to be asked. And Husna has asked me how many readings of Bailey. I don't think it's not about reading. It's about when you read Bailey and then you answer the questions. See if you're able to answer the questions. If you're able to read it once or twice, I think that's more than enough. So anybody who wants to register for the test and discussion, you can just reach out to the helpline. They will be able to help. Guys, I think I had a very good session. You guys are brilliant. You guys are hardworking. I'm sure you'll all do well, but you need to work hard. Okay. So Uswas asked, when can we get the mocks? The mocks will be closer to the exam. But you can create your own mock test on the app. There are multiple options in the app. You can choose how many questions you want to do, so you can do everything. You can create an unlimited number of mocks for yourself. Okay, guys, have fun. Have a great weekend. Give me time till tomorrow. I'll announce the next class as well. Thank you. Have a good day.